Good afternoon, everyone. Thank you very much to all my colleagues attending the Hepático Pernambuco 2021 Liver Talks webinar. It's an honor to begin this scientific event today with a liver talk, liver transplantation, new approaches. It's also a great pleasure to have my special surgeons, Drs. Luciano Beltrão Pereira and Fábio Moura from Pernambuco, whom will moderate this roundtable and will introduce the international speakers, debaters, and presenters of the clinical case. We also prepare a small tribute to celebrate the Hepático Pernambuco Silver Jubilee. Welcome to Liver Talks today. Also, I'd like to say my special gratitude to Nigel Heaton, that is a great partner for a long time for the Hepático Pernambuco scientific meeting. Thank you very much, Nigel, and all team from King's College Hospital.
15 anos do IFP, Instituto do Fígado e Transplante de Pernambuco, e 25 anos do Congresso Hepato Pernambuco. 2 datas, 2 motivos para celebrar o conhecimento. O IFP tem muito orgulho de participar mais uma vez da organização deste evento, que reúne especialistas do mundo inteiro. Já foram mais de 150 participantes nacionais e 60 internacionais de várias regiões do mundo, dos 5 continentes que já participaram deste, que já está entre os maiores congressos nacionais na área de hepatologia. Grandes nomes da medicina internacional e nacional já estiveram no evento, o que deixa a gente que somos os nomes por trás do IFP muito orgulhosos e felizes por saber que estamos no caminho certo, o caminho do conhecimento. E é também em nome de todos aqueles que nos ajudaram nestes 25 anos que estamos aqui para agradecer 25º Congresso Hepato Pernambuco e 15 anos do IFP. Conhecimento que ultrapassa fronteiras.
Okay, I'm going to introduce my colleagues, Professor Kevin Moore. Professor Kevin Moore is a professor of pathology of the Department of Education, Division of Medicine, University College, Institute for Liver and Digestive Health. Welcome, Kevin. It's a very nice pleasure to have you in our meeting. You have 1,364 participants in the room at the moment, 100 participants. Please. You're going to talk about the management of hepatorenal syndrome.
So, Leila, thanks very much. It's really a pleasure to be here, and again, this is really like a tradition now, and hopefully we will at some point we will be able to meet again in person. So today I'd like to talk on long-term outcomes of immunosuppression, and we all know that really the increasing number of agents that, So we had increasing number of agents that were increasingly more potent over time, and this resulted in a significant reduction in the number of acute rejection episodes. And at the same time, this paralleled an increase in survival, short-term survival, which is now in most centers higher than 90% at 1 year and probably higher than 80% at 3 years in the vast majority of centers that perform liver transplantation. Yet, if we look at several registries, and I'm just using this one from the European Liver Transplant Registry, you can see that there's been a significant increase in the first month survival, in the first 1 year survival. But if you eliminate the first 6 months post-transplantation, there's really not much change in long-term survival among the different transplants cohorts. The reason is that we are really losing a significant number of patients from non-hepatic causes. This, I think, was a really excellent study from Kim Watt, published in 2010, where she really looked at the deaths of patients transplanted between 1990 and 1994. And as you can see, the vast majority of deaths were non-related to the graft, from cardiovascular, malignancies, infection, renal causes, and other. We did a similar study in our own center, but we only looked at patients who were alive 10 years post-transplantation. So presumably very good recipients, very healthy recipients. And then we followed these 167 patients alive at 10 years post-transplantation. And again, non-hepatic causes were the vast majority of reasons leading to patient deaths. And this is a very good study from the northern countries in Europe. They compared post-transplant survival to survival of the general population. And when they compared these two populations, you can see that the survival of the general population is almost 30% higher than the survival of the transplant population, regardless of the cohort, whether it's 1985-99, whether it's 2000-2010. And again, when they looked at the causes of mortality in this transplant population, they were mostly related to non-graft causes. And so overall, liver transplant patients surviving 1 year, they had a 2.4 increased risk of death and a 5.8-fold risk of premature death when compared with the general population. And most of the causes, again, were non-related to the graft, and they were mostly related to malignancy, cardiovascular disease, and kidney disease. So I think really what differentiates our transplant population to the non-transplant population is immunosuppression. And immunosuppression, we have good intentions with immunosuppression. We eliminate rejection, but in the long term, it may really result in a poor outcome. And this is so because particularly immunosuppression plays a big role in cardiovascular disease, kidney disease, infections, de novo cancer, and disease recurrence. And I will touch upon some of these complications. If we first start with kidney disease after transplantation, you can see that patients with normal GFR greater than 60, they're the majority at time, at least they're half of the patients at time of transplantation, but you can see how this rate decreases over time, and there's a significant increase in chronic kidney disease after transplantation. So that by 25 years post-transplantation, this is very long, but by 10 years post-transplantation, about 10% of the patients have reached really a GFR between 15 and 29. The causes of this renal insufficiency progression are multiple. It may be related to the incorporation of the MEL score, which selects for patients with renal dysfunction. It also may be related to the increasing use of marginal donors with increased perioperative complications. It may also be related to the increased accumulation of renal toxicity of immunosuppressive drugs, particularly calcineurin inhibitors. And then there was a time when we had a lot of HCV. This is decreasing, and HCV, as you know, was associated with kidney insufficiency. But now the most common cause of transplantation in many centers is NASH. And NASH, again, is also known to be associated with kidney insufficiency. In addition, there's many data really showing that we don't really need to increase our TAC levels greater than 10 in the first month post-transplantation, because if we increase these levels more than 10, we have a significantly higher risk of developing kidney failure, and we don't reduce the risk of rejection. In addition, there are some combinations of drugs that may help us in reducing kidney dysfunction. There are interesting data suggesting that if you combine mycophenolate with interleukin-2 receptor antibodies and reduce doses of tacrolimus that are started 5 to 7 days post-transplantation, this is associated with a reduced risk of developing kidney dysfunction. There's also data, as shown on this slide, that by combining everolimus to reduce doses of tacrolimus, again, you can maintain greater kidney function over time compared to the typical standard tacrolimus doses that we used in the past. So I'll now move to the second complication that is a very common cause of death after transplantation, and that's cardiovascular disease. This is a meta-analysis that shows that overall transplantation per se can be considered a moderate high Framingham risk category without any other additional factor. It is true that there was significant heterogeneity between these studies, but overall, this was the conclusion of several systematic reviews and this meta-analysis. And in fact, if you look at the risk of cardiovascular events post-transplantation, they increase progressively over time, but at 10 years post-transplantation, there seems to be an exponential increase so that it is even more common after 10 years post-transplantation. And kidney dysfunction appears to be a strong factor associated with the development of cardiovascular events. And as we just showed, kidney dysfunction increases progressively after transplantation. Not only kidney dysfunction, renal insufficiency increases progressively after transplantation. This is a list of all the cardiovascular risk factors that we know and their percentage before transplantation and how they increase over time. Most of these risk factors, for instance, obesity, 11% at transplantation, 29% 10 years post-transplantation. And if you look at the number of cardiovascular risk factors, at transplantation, only 1% had 3 or more of these cardiovascular risk factors. 10 years after transplantation, 37% of our patients have more of these cardiovascular risk factors. So we know that these cardiovascular risk factors also are associated with the use of our immunosuppression. We know particularly that tacrolimus is associated with diabetes, hypertension, mTOR inhibitors, they're associated with dyslipidemia. So all our immunosuppressive drugs, they prevent rejection, but they have side effects, particularly related to the increase of these cardiovascular risk factors. This is a study from our own center, again, looking at the number of patients developing cardiovascular events, 15%, and how kidney function at transplantation, together with the Framingham risk score, were the strongest predictor of development of these cardiovascular events in the long term. What about recurrence of cancer? And I won't touch upon de novo cancer because this could be extremely long, but we have data, and this is all retrospective, but quite interesting data showing that high exposure to CNI is an independent risk factor of HCC recurrence. In the this first study, Manuel Rodriguez Peravele showed that patients who receive high CNI exposure have a significantly cumulative disease-free reduced survival compared to those on reduced CNI exposure. And in fact, high exposure to calcineurin inhibitors was independently associated with recurrence of hepatocellular carcinoma after liver transplantation. And this high exposure was defined by TAC more than 10 the first month or cyclosporine more than 300. There are many additional data that has really confirmed this association between calcineurin inhibitors and their higher risk of development of recurrent hepatocellular carcinoma. There's also a lot of data that has been published. Unfortunately, most of the studies retrospective that suggest that mTOR inhibitors may be a good choice to reduce the risk of recurrent hepatocellular carcinoma. Unfortunately, there's only one prospective good performed study, which was very slow to recruit the patients, but overall, it did not show a benefit of mTOR inhibitors in terms of reducing the recurrence of hepatocellular carcinoma. So I think we still have more to investigate regarding HCC and the use of immunosuppressive agents. And I would like to finish just saying that the problem currently is that we are transplanting more and more NASH patients in the setting of the pandemic of obesity and diabetes. And so NASH is now the first cause of liver transplantation in the United States in women. It is not yet this very high level in Europe or in Asia, but I think it will become one of the main indications of liver transplantation in the future worldwide. And we know that NASH is associated with, as I mentioned before, all the cardiovascular risk factors and also kidney dysfunction. So can we do something to improve our outcome in our patient? And the problem is that in terms of managing immunosuppression, we are still using very broad and vague concepts. We use our induction regime and our early regime based on really the clinical status at time of transplantation to reduce, particularly to preserve renal function or neurological function. And in contrast, we switch these drugs in a time of maintenance because the patients develop immunosuppressive related complications. It's not that we are really introducing a pre-elective change of these immunosuppressive agents. Furthermore, and I will finish my talk with this slide, we have a problem in terms of tailoring immunosuppression. We don't know whether we should do it quantitatively or qualitatively. In terms of quantitatively, how much drug is to be administered, our main problem is that drug exposure is a poor indicator of immunosuppression. And in terms of qualitatively, what immunosuppression to be used, what schedule, for how long, the problem is that we really don't have a good measurement of the reliable pharmacodynamic or immune pharmacological markers that are really representative of qualitative immunosuppressive status. So in fact, qualitative tailoring, as I mentioned before, switching drug categories is often implemented as a downstream policy in the presence of immunosuppressive related complications. Thus, I think we still have lots of work to do, and particularly in terms of developing biomarkers of immune status. Thank you very much for your attention.
Thank you very much indeed, Marina, for a very precise talk and very interesting for us physicians. I pass to Eloyd if you have some questions, and for the others.
Good afternoon. First, I would like to agradecer to Professora Leila. Marina, thanks for your excellent class. I would like to ask, in late transplant, we had a protocol we take off the tacrolimus in patients who has a severe renal dysfunction. We do a biopsy to remove the tacrolimus after 2 years. When the biopsies comes later, rejection, what do you do? I would like to take off the tacrolimus. Do you use to do this?
We do a lot of monotherapy with mycophenolate and also with mTOR inhibitors. I must say there are many data showing that with mycophenolate it is feasible, but some patients eventually reject if you maintain them on mycophenolate. I think it's something that we all need to do because these drugs are particularly harmful in terms of cardiovascular complications. But I personally think that we need to make sure that in the early post-transplant setting, we don't really overtreat our patients. My impression is that for many years we were afraid of rejection, and we were completely obsessed with rejection, and we used to over-immunosuppress our patients. I think now we are kind of switching to the other side, and we are kind of reducing tacrolimus, eliminating tacrolimus, and switching to monotherapy. And we eventually, in some of the patients, it's not a huge population, but it's a percentage of the patients that eventually develop rejection by switching to either monotherapy or no immunosuppression at all. The second problem I see, and we do this a lot because we have patients who've been transplanted 10, 15 years now, and so we eliminate all the immunosuppression, and we know that as the time evolves from the time of transplantation, and if more than 10 years have gone past transplantation, you have a higher chance to really reach a status of tolerance in your patients. But then it's just so late that the patients have mostly developed all the complications, particularly kidney dysfunction, and it's irreversible. It's very rare that at the time that you start doing all these changes in immunosuppression 10 years after transplant, it's very unlikely that you will go back and change the status of your patient. So the changes need to be done early after transplantation. And I think there are regimes that can be used, interleukin 2 receptor antibodies. I think they can be used initially to postpone the introduction of tacrolimus and perhaps use lower doses of all these drugs. But the problem is we don't have a marker that tells us how immunosuppressed the patient is. I think that's the main problem.
When too early do you take off tacrolimus?
I sometimes even, it depends on, as I mentioned, we do it depending on the complications, but sometimes even 1 year after transplantation, I start, some of my patients are already on monotherapy. You can do it, if you do it with mTOR inhibitors, you can do it much earlier. You can start at 1 month post-transplantation to start the reduction of tacrolimus, and by 3 months after transplantation, you can be completely off in calcium inhibitors and leave the patient with mTOR inhibitors. But with mycophenolate, that's not feasible because it's not sufficiently potent.
Thank you.
Eloide, can I listen to your opinion from your experience from Nigel and Mohamed? Because I know that King has some experience to take out all the immunosuppression later on.
Can you hear me okay? Well, I think Alberto Sanchez-Fuero is undertaking programs of prospective immunosuppression withdrawal and looking for biomarkers. My message to our patients is immunosuppression minimization rather than withdrawal at the moment. But there are patients who want to be included in immunosuppression withdrawal trials. They feel very strongly that they would like to come off this medication, which they see as intrusive and damaging. So I think, as Marina has said, the key thing is early identification of complications and minimization and changing of drug regimens. And in the longer term, really trying to manage patients as individuals and slowly reducing their immunosuppression. The problem is within a big program, there will be someone who will reject long-term as you wean their immunosuppression. And then everyone says this is a disaster, it's completely wrong. But the immunosuppression load that the other 3,000 or 4,000 patients bear is huge, as Marina's clearly pointed out. So I think this really needs dedicated people providing really cohesive care for the patients.
And Nigel, I also think that the problem is that we have not really shown, because when we withdraw the immunosuppression, typically is like by several years post-transplantation. Typically after 10 years, because it's when it's kind of the cutoff when they say, okay, this is the time where you can start. And we have a lot of patients without immunosuppression. but it's so long after transplantation that they have already developed all the complications. And I personally haven't seen a benefit in this, in the outcome of these patients in the long term. So the other part of the picture is that I think that we have not really shown that by doing this minimization too late after transplantation, we make a change in this mortality that I was just showing. And so all these studies need to be done, and we need a biomarker to do this early on after transplantation.
We have one question from Q&A, is Professor Rita Silva from São José do Rio Preto, São Paulo. Marina, do you have a time limit after transplantation to shift for monotherapy on immunosuppressor without tacrolimus? I think you just answered that, but you could mention.
I don't have really, I mean, generally speaking, I don't like to eliminate tacrolimus completely before 1 year after transplantation. And generally speaking, I try to maintain tacrolimus for a much longer period. And I do as, I think we need to take advantage of all the drugs and their side effects. So it's very good, for instance, to have the patients on tacrolimus very low levels and mycophenolate, for instance. And so you take advantage of the potency of tacrolimus, but you lower very much the dose so as to reduce the side effects, and then you combine it with mTOR inhibitors or with mycophenolate. But if you need to do it, I mean, you can do it even 1 month after transplantation, because if you have patients, for instance, who develop a very severe neurological complications, you are obliged to stop these calcineurin inhibitors. Well, then you switch and you use mTOR inhibitors together with mycophenolate, and you do whatever you can to maintain your graft without rejection. And it's the liver is quite tolerant, so it's not always followed by rejection.
Right. Before you switch to the others speakers, any debaters or case presentation would like to ask any question for Professor Marina?
There are a couple of questions on the protocol, and well, we used to biopsy a lot. It's when you have a center that does so many transplants, it's just impossible. At least if they're not in a protocol, I don't biopsy my patients always before reducing tacrolimus and stopping tacrolimus. If I maintain them in another drug, I typically don't biopsy them if their livers are okay. And more so now that we don't have HCV. And if they have some degree of liver abnormalities, then I do biopsy. And generally speaking, I must say, if I withdraw all the immunosuppression, generally speaking, it's because it's patients that are older. They've been like 10, 15 years transplanted. And I do it very, 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 very slowly until I eliminate completely the last doses of mycophenolate. And I don't biopsy them because I don't know, they're like in their 80s or something like that. So I don't really biopsy them.
Denise from Ceará asked if you use sirolimus instead of the tacrolimus.
We do the sirolimus, and was the first kind of drug, the first mTOR inhibitor that was in the market. I still have patients on sirolimus, and they are on 1 milligram or 0.5 milligrams per day on sirolimus for like 10 years, and they're doing just great. But now the drug, at least in my center, is no longer available for. We switched to everolimus, and it's the drug that is marketed and that we can use for our liver transplantation.
Okay, in our experience here, Marina, I'm very unusual today. I think I can't have only one patient without that I take out all the immunosuppressor, because I'm worried to be a disaster if they have some rejection later on. We try to keep low doses for the patients, someone only monotherapy for longer, and manage cardiovascular risk and NASH as well. That is quite often in our patients at the moment. But
I think it's a very good, as Nigel was saying, I think it's, I mean, minimization probably is the same as eliminating, because we typically don't do it very early. I think the good thing, if we wanted really to avoid all these complications, that we should be reducing substantially our drugs much early after transplantation. But then we don't do it because we don't really have the tools to do it. We try to do it, but we are probably too slow in the process because we don't have enough tools. And we need to follow up these patients very, very carefully with a lot of blood tests. And sometimes it's also, we don't have enough hands to do all this work with so many patients.
And I think the last question for the audience from the Q&A, what is your preference about immunosuppression in HCC patients?
In HCC patients, I think the data, there are some, even if the prospective study on mTOR inhibitor was not suggesting an advantage for mTOR, there are now, I think, already 5 systematic reviews and meta-analysis. The last one published, I believe, last year or 2 years ago, and they all point towards the same idea that with mTOR inhibitors, the recurrence of hepatocellular carcinoma is lower and the survival is greater in the patients that we treat. So in general, we treat our patients with TAC plus mTOR inhibitors, and we eliminate TAC as fast as we can after transplantation.
Okay, Marina, thank you very much indeed. I have to move on to the other speaker, and I ask you, Luciano, to introduce Professor Nigel Heaton.
Hello, thank you very much, Professor Marina. That's a consultant hepatologist from Lafayette University Hospital and a professor of medicine in University of Valencia, and did her post-graduation in California, University of California, and is also a close friend here from Brazil and Recife that unfortunately could not come this time due to COVID to have this sunny place in the beach as our traditional event. And thank you for the lecture. And we had an inversion of the program. So we had this chat now and debate with Professor Marina. And I'd like to introduce Dr. Fabio Moura. That's a colleague from Recife, a great partner here from the Institute of Liver Studies of Pernambuco that is responsible for the transplants and HCT cases, and the chief surgeons in the Real Hospital Português. And he will present the debaters and the clinical case presenters after this lecture now. And for the lecture now, I'd like to introduce Professor Nigel Heaton. That's also a great partner of the event and full professor and consultant lead in King's College Hospital in pancreas, liver, and transplantation, and lead in the area of King's College. Professor Heaton, please start, and welcome to the event once again.
Luciano, thank you. I hope you can hear me okay. So today I'm just going to have a brief review of the surgical evolution of pediatric liver transplantation. Obviously, it's something very key to my heart. On the left of your screen is Morio Kasai, who really provided the template for patients, for children requiring liver transplantation. So I look on him as the grandfather of transplantation. Ted Howard, who's in the middle of the picture, was someone who trained me and established pediatric liver surgery at King's, and I think set the scene for our future. And Tom Starzl, who was the pioneer for transplantation. Now, I'm going to briefly talk about the surgical techniques. I'm not going to say much about changing indications. Biliary atresia still forms the main indication, but what we see is increasing complexity with particularly a wide variety of metabolic liver diseases being referred for transplantation. There isn't really time to talk about long-term outcomes very much, but I'll touch on that. Transition and the care of young adults is increasingly important, particularly as we see larger numbers of young children coming through. And we see complexity of transplantation, and I'll say a few words about that. There isn't space to talk about organ preservation and machine perfusion, but even in pediatric practice, I think this will become increasingly important. And I think a question for the transplant community worldwide is around access to transplantation and affordability. It's all very well for me to talk about it in the UK where it's free, but most countries around the world, this is probably the most important discriminating factor for access to transplantation. So Tom Starzl recognized that children are particularly robust, and his initial attempts at liver transplantation were in young children, primarily with biliary atresia. And this is his paper from 1968 reporting the first successful transplant from 1967. At that time, they were transplanting whole livers, and this diagram shown here from Tom Starzl's book on liver transplantation with the anatomy as demonstrated. This is Carl Groth with some of the very early survivors of their program. And you can see that the majority in those early days were children. It took Roy Kahn and the introduction of cyclosporin to really open up liver transplantation. So from 1982 onwards, the number of transplants was increasing. And so for the first time, there were demands to transplant children. You can see from Roy's early experience, again, publication of the first 5 cases in 1968, that the concept of piggybacking liver transplants was already there. Roy was filleting out the old liver and piggybacking the new liver. It's already starting to develop the concepts that we become familiar with now for pediatric liver transplantation. So that early experience was transplanting whole livers, and they had to be made to fit. Naturally, there were restrictions on the size of children that could be transplanted. In the UK, even as late as 1988, children under 10 kilos were not offered transplantation. So in the 60s and 70s, a number of anatomists were describing the liver anatomy and demonstrating, as here, the Quino segments, the segmental anatomy of the liver, which allowed for the prospect of livers to be cut down. The left lateral segment in particular, allowing for a 10 down to 1 size reduction. Sorry. And so it was Henri Bismuth who reported in, I think it was 1984, the first liver resection. Actually, I think I heard Tom Starzl say, no, it wasn't. He'd put in a whole size liver, which was too large for a child, and did an extended right hepatectomy in the child at the end of transplant. But I think Henri Bismuth was the first to do it as a planned procedure. And you can see here, his background was that of an HPB surgeon because he's done an extended right hepatectomy because the cava, the adult cava, remains intact, and he's used that for implantation. But again, this was the seed of the idea which was developed hugely on from that. And here we have Rudolph Picklemeyer, who was the first to suggest and to perform split liver transplantation using the left lateral segment for a child and the right for an adult. Again, developing this hugely important and successful technique. And then finally, Silvano Raya was the first to pioneer left lateral segment living donation with this report from the Lancet in 1989, followed closely by Russell Strong, who had the first long-term survivor using this technique. I just put here our first couple, mum and daughter, from 1993, to show that this is a wonderful technique. It provides an excellent quality graft with long-term survivors. And I think all of our first 7 living donor liver transplant children remain alive 26, 27 years on from their transplants. It was Christoph Brosch, though, who really established living donor liver transplantation as the surgical technique with this pilot study of 20 cases where they described their surgical techniques. I think for me, this was probably the most important thing that I learned in liver transplantation, was this technique of the triangulation of the caval anastomosis to piggyback the left lateral segment onto this. So it's got a very short cuff, and this allows for left lateral segment transplantation with a very low incidence of venous outflow. And I think in our transplant program at King's, we went from doing very small numbers, maybe 10 a year, up to 40 to 50 a year by 1995. So I think for me, this slide shows the most important technical lesson that I've learned in liver transplantation. Sorry, I've already shown that. So this is the left lateral segment, and clearly these children are getting a normal sized liver. In no way is this inferior, and this accounts for the widespread adoption of this technique. And if you look at Europe today, progressively over decades from 1990, living donor liver transplantation has become a more important source of organs. Clearly in the East, with the lack of cadaveric donation, this has been really, until recently, the only option for transplantation of children. And here, this is the other challenge that I think has really driven pediatric liver transplantation. How do you transplant small children? How do you get a piece of liver that's small enough? And here, we started many years ago with cutting livers down to produce so-called monosegment grafts. But in this paper, which includes one of our former fellows, Moreo Kasahara and Mohamed, they've described the technique of true monosegment transplant, of being able to provide for up to a 20 down to 1 size reduction. So being able to transplant neonates from adults. So we've seen the full development of liver transplantation in children over this period of time. And then for me, another important part of that journey has been the development of auxiliary liver transplantation, whereby for a child with acute liver failure, you can put an auxiliary graft in, whether it's a right lobe as demonstrated here, or more commonly a left lateral segment for replacement. You can keep these children alive and allow for progressive recovery and regeneration of the native liver. And the important aspect of this is that you can withdraw immunosuppression in over 2/3 of children. This is a slide of our data from King's of the long-term outcomes of auxiliary liver transplantation, shown here in blue. What you can see is that you have no late deaths from the side effects of long-term immunosuppression. So the auxiliary liver transplantation seems to impart long-term survival advantage because of the lack of immunosuppression continuing. So auxiliary liver transplantation for me is the gold standard for the treatment of acute liver failure in both children and young adults. So I've said split liver transplantation is fully established, but actually it hasn't been popularized. And I think there's still work to do to try and make sure that this technique is utilized worldwide. This is showing it in practice. Splitting for right lobe, full left lobes to try and transplant adolescents and young adults still remains, I think, the cutting edge, the problem that still needs to be properly solved in transplantation. And then moving on, multi-organ transplantation has come of age and really now is part of the routine of pediatric transplantation. And one can transplant liver, small bowel, and colon and achieve satisfactory results. And again, with progress, we've shown that you can perform living-related small bowel, but also liver and small bowel transplantation. And this is our first case of a left lateral segment and small bowel from the mother shown here, with the child who'd had 2 previous bone marrow transplants and had this rare genetic mutation associated with intestinal atresia and combined immunodeficiency. And here she is 2 years post-transplant with a well-functioning liver and small bowel grafts. So these sorts of developments are possible as you gain more experience and confidence in all of these surgical techniques that I've been describing. This is from the Intestinal Transplant Registry, but the message I'd like to show is that for isolated small bowel, and even here in purple for multivisceral transplants, the short-term and long-term outcomes are improving. And these shouldn't be considered as experimental techniques and should be offered to carefully selected patients. And then new problems are emerging with long-term survival, here with demonstrating a case of splenic artery steal in association with massive splenomegaly. And you can see here on this CT how small the common hepatic artery is compared to the splenic, and the massive blood flow going through here and feeding existing collaterals. And you can demonstrate here again, this is showing the same patient, the splenic artery, and now here with splenic artery embolization, infarction of the inferior pole of the spleen to reduce splenic flow, reduce the complications of splenomegaly, and improve the patient's condition. Here we've also started doing it surgically. So here's a patient with massive splenomegaly, ligation of the splenic artery, and then a distal splenectomy or hemisplenectomy to help with getting rid of the collateral circulation, which is usually or more commonly associated with the inferior pole of the spleen, and to aid the recovery of the patient. And these sorts of things, I think, are becoming increasingly important. You've already heard about immunosuppression, so I'm not going to say anything more about that, other than tailoring the immunosuppression, early identification of calcineurin inhibitor complications, and the future is around monitoring of immune status and the development of novel tests or biomarkers to try and do that, and waiting for the results of clinical trials to see whether we can clearly identify tolerance and have immunosuppression withdrawal. In terms of late graft dysfunction, well, children have been particularly interested over the last 20 years. We've seen the problems that occur from late non-adherence to medication and mortality, and therefore the need for transition clinics to look after adolescents. We've seen the identification of late non-specific hepatitis and the possibility of under-immunosuppression, the emergence of de novo post-transplant autoimmune and donor-specific antibody injury. And as I say, we're seeing the late complications that require attention. I think now we're seeing challenges for the young adults who've been transplanted as young children. They're coming through into adult life. Sorry, I'll go back. Relatively vulnerable, often looked after or cared for to a greater extent by their parents. They're not really ready for the adult service. Some of them may have delayed puberty and will certainly have delayed social, academic, or intellectual development. And we have to be giving them, preparing them for lifestyle changes. No alcohol, no smoking, don't get fat. You've really got to be adherent to diet and exercise. So this, I think, is a new challenge. We've also got to look at children in terms of when do we do transplant? It's tended to be defined by progression of liver disease, of using criteria that we judge adults by. In the older children, it's dominated by portal hypertension and hypersplenism, and the variants that you see, particularly around hepatopulmonary syndrome and pulmonary hypertension. But I think we should be looking at how to ensure their intellectual development is optimized, their physical and social development. And what's clear is the later you transplant children, the worse the outcome. The best outcomes are in children under 10 years of age. The worst outcomes are in the 15 to 30-year-old young adults. So how can we change this? What can we do? Is it by timing? Those are the challenges in liver transplantation today. As I say, people are fixated by organ preservation and machine perfusion, which I think will have a role in pediatric liver transplantation. But for the children, the challenge is a normal lifespan. The longest survivor worldwide is coming up for 50 years post-transplant. So we need new types of medical care, not just post-transplant, but an adolescent, young adult, and its attention to the little things. There's a paper coming out now on the European transplant database, which suggests the half-life for livers for children who survive the first year post-transplant is 41 years. This means the majority of the children we're transplanting should survive long-term, but it needs the medical profession to step up and to really manage these patients tightly if this type of outcome is going to be available for all children. Thank you very much.
Thank you, Professor Nigel, for this brilliant presentation. And now I will call Dr. Hector Melendez, is consultant at the King's College, to talk about this. Oh, sorry. We call now Dr. Gil da Porta to present us with a case, and then after we have a discussion about this case. Dr. Gil da Porta, it's a legend in pathologist, pediatric hepatology here in Brazil. We have some cases that we send to São Paulo, and she has a long time successful group of pathology who came people for all the country, all the Brazil. So like to present her.
Fabio, just one thing. The questions for Dr. Heaton, you're going to do it right now or afterwards?
Thank you very much for inviting me to this meeting. It's an honor for us to present here in Hepato Pernambuco from Dr. Rela. And I will present today, me and Dr. João Seda, we work together at Sírio-Libanês Hospital Menino Jesus in São Paulo. And we present today a case, a child, pediatric liver transplantation. It's a child, 8 months old, male. He's originally from São Paulo. And the diagnosis was biliary atresia without previous portal enterostomy. He was submitted to liver donor liver transplantation, and the father was the donor when he was 8 months. The first transplant occurred June 27. He had early complication, hepatic artery thrombosis, and he was submitted with anastomosis. The primary immunosuppression was prednisolone and tacrolimus. On POD10, he developed a bilious ascites, and he underwent a surgery, a laparotomy, and they found hepatic artery thrombosis plus fistula, biliary fistula. So he needs a new transplant, and he was submitted 20 days after first transplant, again, a new liver donor liver transplantation, and now the mother was the donor. This second transplant went very, very well, and he was discharged from the hospital on POD10 with normal liver function tests. 6 months after the second transplant, he had acute BV infection, and the Doppler ultrasound was normal. And in this occasion, we decreased the tacrolimus to very low levels, but he developed intestinal PTLD, and we decreased very, very low levels of tacrolimus, and the PTLD was doing well and disappeared. We did again another colonoscopy and disappeared PTLD. In June 2010, he had first time upper GI bleeding, was submitted to endoscopy, and have variceal bleeding, and he underwent allegation of esophageal varices. In this occasion, he did abdominal CT angiography and had portal vein thrombosis. We did study for thrombophilia, and the screening was normal. This is the first CT in 2010, showing here a portal vein thrombosis, splenomegaly, and a very poor intrahepatic vascular bleeding bed. So we tried to intervention radiologists, combine the portal vein recanalization, but failed to do this. And he developed, he continued to have bleeding, and he had been hospitalized several times because he has a lot of bleeding, and he did several GIs endoscopy, but failed to eradicate his esophageal varices. In 2017, elastography was normal. We did a liver biopsy completely normal, without acute rejection or infections. And in this occasion, the tacrolimus serum levels was 2 and 3. And we did a new angiography in 2018 and show a distal splenorenal shunt and a cavernomatous transformation of portal vein and a very poor intrahepatic vascular bed. So he continued to have much bleeding. He had been hospitalized several times. He underwent several upper GI endoscopy, and his quality of life is not doing well. So in 2019, he underwent a modified mesocaval shunt with a larger collateral vein from Ru-in-Y limb that Dr. João Seda will present better for us. We did after this surgery several times. The level of ammonia were completely normal. EEG is completely normal, and he had a very great improvement in quality of life. Now, the question of discussion, and Dr. João Seda will present now our algorithm for post-transplant portal vein thrombosis in these patients. Dr. João Seda, please.
Thank you. I'm just going to complete Dr. Porta's presentation. We have a long-term problem in pediatric transplants, which is the chronic long-term portal vein thrombosis. It's still an unsolved problem for us, and we have performed around 1,300 pediatric liver transplants. Our incidence of long-term thrombosis is 4.3%. We have 55 patients that develop long-term thrombosis, chronic thrombosis. And we have developed our algorithm for treatment of these patients. Actually, if with a screening, you check the platelet count, it's dropping. You look for the portal vein thrombosis. Our first assessment for these patients is the interventional radiology. We started doing a combined procedure around 2010, and now the interventional radiology team, they usually do the recanalization of the portal vein through the spleen. So if we have if we have a good flow, it's okay. So the patient improves. If we don't have a flow, these patients go to endoscopy and sclerotherapy. you can eradicate the varices, and then obviously you stop having problems with the portal hypertension at this time. But if the patients continue to bleed, and you have GI bleeding, these patients need to be readmitted to the hospital many times. So right now, and if we fail the intervention radiology procedure, we don't at this point here, we don't wait for the clinical symptoms, but here, if patients are bleeding, we try to study the patients and to try to find the best surgical approach for them. Of course, if the vascular intrahepatic vascular bed is good, the mesorect shunt is the preferred option. But we usually do the angio-CT and the dynamic angiography with the venous phase, so that we can determine the best shunt for these patients. It took us a while in this case here, but this patient underwent a mesorect shunt. If you can go back 2 slides, I'll show you what was the. Can you go back 2 slides?
This?
No, another one. So this is the Roux-en-Y limb. Go back there.
No, we don't have another one.
No, the next one. This one. So antes, Júlio.
Esse daqui que eu tenho. Só.
That's that one. So if you see, there is a huge varice here going up on the Roux-en-Y limb. So we disconnected this vessel here, and we brought it to the vena cava. And then we performed the modified mesorex bypass. And in this case, we had the improvement in the patient's conditions. Próximo. Pode passar o último lá, Júlia. So from these 55 patients we have with chronic portal vein thrombosis, we were able to successfully recanalize the portal vein in 32 cases, and in nine circumstances we could not have success with the process. But we think that it's an interesting approach. I know that it's very many different centers treat it differently. Most centers, I think, they do mesorex bypass straightforward. But what's important to mention here is that these stents, when you have the stents, and if you rethrombose them, you can recanalize them. 20% of them we needed the revision of the stents, and they do not. It's not prohibitive for you to do a mesorex bypass or any kind of surgical bypass after if you have failure in the IR treatment.
Dr. João Seda, it's a surgeon for the hospital Sírio-Libanês, one of the biggest experiences here in Brazil in pediatric transplant. I had experience with him with reducing liver when I was a resident here in USP. It's one of the fast reduction liver that I saw in my life. It's a great surgeon. And we have to we have to discuss this case. Great case, by the way. A very challenging case. Dr. Hector Melendez, it's a consultant surgeon at the King's College. And Dr. Rafael Vasconcelos, he's a surgeon from the service at the Luciano, help me please.
Is the Center State Hospital in Rio de Janeiro, Instituto DOR. He's also had experience in France and trained in the group of the Federal University of São Paulo during his residency, and has experience in pediatric transplantation. I would also like to mention Professor Akin Tekin from Miami Jackson Memorial is also in the room. Also has a great experience in liver pediatric transplantation and multivisceral. Thanks, Professor Akin Tekin, for participating also in the room. And I think we would like to hear Fabio and colleagues and Professor Seda experience also of Professor Mohamed Rela and Professor Nigel Heaton, and to debate and interchange these ideas. So for the debate, I think Professor Seda, Professor Rafael, Akin Tekin, you have the word, you have the experience.
No, I have to say that Hector is in the transplant now for that reason.
Yes, Hector is in the transplant,
Okay.
so he asks. Sorry.
Hi, everyone. Thank you, Professor Leila and Dr. Luciano for inviting me to this meet with all of these experts. I have many questions. I want to choose one. I want to know of all experts what they think about of the split liver transplantation and from cadaveric donor. I'm really enthusiastic of cadaveric donor. In the last 10 transplantations that we performed, we use cadaveric living donor, cadaveric split liver in 80. And I want to know what they think about of cadaveric donor using split liver in pediatric transplantation. And I want to know about SIDA, if they perform with this case, if he think about this connection as a portal with splenectomy.
Nigel, can you answer the question?
Okay, so in the UK, we have mandated livers from donors under 40 years of age should be offered for splitting, so that we transplant children and adults. Even with that in place, the number of livers coming through doesn't always match up with what we would expect to come through. So there's still a reluctance from some surgeons to offer up and to use right lobes, because there is no doubt it increases the short-term complications that you experience, at least within the adult recipient. However, it is a fantastic way to transplant children and to maintain the overall numbers. And I think for surgeons who are used to doing living donation, it's a big advantage when it comes to doing split livers. With regard to the case presentation, I mean, I thought that was really interesting. I mean, we see it all the time, and I think it's one of the big challenges in children with biliary atresia, both in the very young, but as they get older. I think it's always useful to measure an ammonia, because any child that has a raised ammonia will be shunting. And if these children are shunting, then unless you do something about that, they will be a long-term problem. I think all children with biliary atresia, and certainly those with portal hypertension, should have cross-sectional imaging either with CT or MR, again to identify patterns of shunting, particularly in association with splenomegaly. At the time of surgery, you should be looking out for a small portal vein, because these patients either need portal vein replacement or a portal venoplasty. I think we favor portal venoplasty now to open up the portal vein and then to ligate the collaterals. Moreo Kasahara in Japan has written extensively on routine ligation of all of the collaterals in every child. I think any child that has early portal vein thrombosis, it's always due to missed collaterals and to shunting of blood. So that I think if you're doing portal vein stenting at any time in the longer term, I think it's useful to look for patterns of shunting and to close them off if you can at the time of portal vein stenting. Otherwise, they will thrombose again. We favor doing rec shunts if we're forced to do something surgically. I've gone off shunting children because of long-term outcomes with low-grade encephalopathy. But doing rec shunts in these children late is tricky, it's difficult, and it certainly tests one's nerve. So I think these are really tricky problems, and they'll be providing challenges for surgeons in the longer term.
Can I ask Professor Sira about the technique? He said that you said that you did a modified rec. the CT scan shows large varix running up the roux loop towards the hilum of the liver. And I've seen exactly similar CT findings, and the bleeding actually comes from the roux loop. Where did you connect this to? Did you connect the large varix to the rex recess portal vein, or did you connect it? I thought you said you connected to the IVC.
Yes, in this case, we just released this varix. You know, it's very identifiable, interoperative. And then we just disconnected and we rotated it to the cava.
But you can't really call it a rex then, can you? Because you're not connecting it into the liver.
I'm sorry, it's a mesocaval shunt. I'm sorry.
Okay,
mesocaval shunt. Yeah.
Because I thought you said modified rex. That's why.
No, mesocaval.
Yeah.
I'm sorry.
You know, I had a very similar case where I planned to do a rex shunt, and I went in and I saw this very large vein. So I put an interposition graft between the rex and this shunt. But unfortunately, on day 2, that shunt thrombosed. So I went back and did a mesorex, and it worked well, actually.
What kind of shunt did you use? Deceased donor or
used internal jugular? Cadaveric internal jugular is what I used, because these are transplanted children. So we have stored. Cadaveric iliac vein. Yeah. We
so
stored.
If we go to the literature, you know that. Dr. Jean-David Legoyer and other authors, they always say that we should use the internal jugular vein for performing the rex shunt. I have a very bad experience with the rex shunts. We did 3 cases with deceased donor grafts also, and 6 months post surgery, all of them thrombosed. So I'm a little bit concerned next time I'm going to use the internal.
No, were these done early post-transplant or late post-transplant, the rex shunts? Yeah, late post-transplant, sometimes a problem, because when you connect them and measure the portal pressure, they're generally quite high. And John Deville de Goya says, don't worry about it. It will be high, but it will settle down over a period of time. So that may be a problem. I mean, this kind of problem, which happens within the first year, I think rex shunt usually is not a problem.
So sometimes the varices, particularly in the older children who are late post-transplant, they can have some really very big varices, and you can certainly use those as the interpositional graft. My feeling is if you detect a fall off in flow in that first 6 months, you've missed some big collaterals. And it can be extremely difficult identifying at surgery. So you need a roadmap. And from my point of view, if you see poorish flow, you should get your radiologist to go back down the shunt and to look for any collaterals and to close them if you can. And I think it's worth spending a lot of time trying to close off those collaterals. I mean, it's extremely difficult late post-transplant, as you've already described, but you have to do that. And then the other thing we've been trying is putting stents down the rex shunt, holding it open, so that you can get quite nice shunts that fit now and hold that open. But as I say, the key thing is to close off the collaterals.
The only thing is that it's a pretty long, right? When you use shunts for the rex shunt, so you need pretty long stents to keep them open, or multiple. I don't know.
So I think that's why Jean Deville de Goya said use the internal jugular vein, because it's of a set length, and it shows how he mobilizes the liver to get the interpositional graft to be of that length. So there's something about mobilizing the liver, trying not to have a long graft, interpositional graft. I agree with you. Sometimes in the young adults, if you go back and try and do it, you require a much longer graft. But our radiologist can put a couple of stents in to try and hold it open. But, you know, I still think the key is the missed collaterals more distally, the siphoning off flow.
Dr. Akintekin, you had some comments, please? Can you put microphone on, please?
Thank you for inviting me too. Obviously, this was a very difficult problem, but I know why the surgeon chose that option, because it was right there, a long varix going in the direction of the cava, which is almost natural as long as the vessel quality was fine to do this. I don't have too much experience with the Mesorex, but I have performed a significant number of distal splenorenal shunts, which works very well with these problems if you have a good splenic vein and caliber. I see that there was a spontaneous shunt there, but it was very small as far as I could see from one image. That would not be enough to decompress, and obviously it was not. And when it comes to stents for the kids, especially for the portal vein, most of the time they don't work, and when they clot, there's no fix for them. For the shunt you performed, I have a patient right now on my transplant list, cirrhotic patient, a kid who had exactly similar shunt, which clotted in time, and they stented it, and it worked for a while. He's now 13 years old. But then it went down, they couldn't revise it a few times. We tried to attempt, and now we will try to do a transplant with the jump graft from the confluence of the splenic vein and SMV. There is flow there. And also, since this was a transplant patient, I don't know whether you have an access to cadaveric vein grafts that you could use sometimes if you want to do a different shunt, and it would not be an issue as long as the regulations allow you. That's one thing. And for us in Miami, we have obviously a little bit more options. If things go down on the road, we have an option of multi-organ transplant, change the whole portomesenteric system if needed in the future. But obviously, these are big problems with the kids, especially venous problems. Arterial problems, for me, it's easier to fix because you can have options, but the vein, especially when they start clotting, and there is also aneurysmal dilatation as far as I could see in the splenic and the mesenteric vein area. And then when you do a shunt from there, probably it will clot too. It's like a lake there. Those are the things I could add if it works. Thank you.
Thanks a lot for this great debate with all this international experience. I think we have a question here from the Q&A from Professor Ilka Boyne from Unicamp for Professor Seda, if he has performed vascular anastomosis using vascular cadaveric donor grafts, or if you have any comments to finalize the debate, Professor Seda and colleagues, so we can move on. Thank you.
Well, in this case, specifically in this case, we just rotated that varices, the one from the Roux-en-Y limb, rotated down to the. We didn't need to use vascular graft for this anastomosis.
But have you? I think if you have any experience of using vascular cadaveric donor grafts in other cases, or
yes, for sure.
Yes.
Yeah. Usually during primary transplant, when the portal vein is not good, Dr. Heaton, he said they enlarge it. We just go to the splenomesenteric junction and we put a graft there, mostly for live donors.
Thank you very much. So I think was a really nice debate. Fabio, thank you also for the moderation in this part. And I think we could ask Professor Mohamed Rela to give the next lecture. Professor Rela is also a senior liver transplant since 1993. Is a consultant surgeon at King's College, together with Professor Heaton, where they worked always together in pioneering and really small children. Also in the Guinness Book, registered as a large experience. Also went back to India in 2009, and since then also has an institute, Rela Institute, in his name, and is leading also in liver transplants and many societies. Thank you, Professor Rela, for participating and being a partner since my Professor Leila was in King's College together with all of you. Nice to have you in the event.
Thank you, Luis. I'd like to thank Professor Leila for inviting me. I think I heard her voice during one of our meetings. It was a surprise that she joined in our meeting last year, I think. And it's lovely to see all of you. And it's been great that there are so many faces from King's. And My title is Liver Transplantation Programs Around the World. It's physically, I think, not possible for me to cover every aspect of it, but I will try and talk about a little bit of my experience and transplant programs in India, and cover the differences between East and West. As Luciano said, I started my career really as a consultant surgeon in King's and became a professor there. I left in the end of 2009 to India to start a liver transplant program. I initially went for a year, but settled there, and I'm very grateful for, I worked in King's for almost 20 years, and it's really what Nigel showed, the experience from there, both with pediatric liver transplantation and split liver transplantation, really gave me the confidence to get to India to start a living donor liver transplant program. And this is the youngest child who had a liver transplant at 5 days of age. And that girl is 22 years old now, and she is a law student, probably a lawyer by now, in Ireland. It's nice to see how successful pediatric liver transplantation is, even when it is performed at such a young age. Apart from this, I think liver transplantation has helped me and most surgeons with really doing very advanced HPB surgery. And the first ex situ resection I did was many, many years, almost 20 years ago in King's for a pheochromocytoma, which was really going into the liver. It's an extraadrenal pheochromocytoma, which was deemed unresectable. But really that has helped us perform many ex vivo resection in India in cases like this, which is a intrahepatic cholangiocarcinoma, including all the 3 hepatic veins, and you can see how congested the liver looks. And it wasn't really possible to perform an extended right hepatectomy because the left hepatic vein was also occluded. But we could really resect it on the bench and extend the left hepatic vein. So there are many techniques like this, and this is a case actually from last week, a very large IVC tumor extending from really the iliac bifurcation up to the right atrium, occluding the hepatic veins and causing Budd-Chiari as well. So I think overall, the experience of adult and pediatric liver transplantation has enabled many liver transplant surgeons to really push the boundaries in transplantation. Now, I think with the success of liver transplant, there has always been, whether it is a beginning of a program in a country or in well-established countries, I think as indications increase, organ shortage has been the issue, whether it is the East or West. But in the Western countries, really the number of organs which has increased has come from extended criteria donors, use of marginal livers, and now I think the use of machine perfusion to rehabilitate livers, and DCDs. I think DCDs came into vogue 2-3 years before I left UK, with phone calls coming. I'm sure Nigel is still enduring all of that, with phone calls coming every night about every patient who's about to die as a DCD offer. So these are the ways that the West has coped with increasing organ donation, whereas in Asia, there has been really a huge problem in developing cadaver liver transplants, and I will talk a little bit about that. So the Asian countries, particularly the Far Eastern countries, took on living donor liver transplantation. And in India, many people who got trained in the West and went back to India initially thought that it should be really disease donor transplant, but they've been really unsuccessful. And if you look at the statistics of cadaver donation in Asia, in the USA, it's about 20 per million on an average, and in Europe, in Spain, obviously, it's about 25 to 30 per million. In South America, in your part of the world, it's better than India, about 2.6 per million, and in Asia, it's less than 1 per million. In India, certainly, it is less than 1 per million. So that is a huge problem, and without the development of living donor liver transplant programs, it's not going to be possible to transplant the population. So really, most of the, you've already heard from Nigel about the pioneers, including Professor Silvano Rea, who did the first living donor liver transplantation for a child. The development subsequently have all come from the East, with the Japanese and Koreans starting living donor liver transplantation in large numbers. But the problem still remains. If you look at Japan as a classical example, where disease donor has never developed, the legislation really was passed in 1997. And if you look to see for another 5 to 6 years, hardly 0.1% of the transplant were done as a cadaveric liver transplant. So the Japanese as a country have never developed a cadaver liver transplant, whereas among the Asian countries, Koreans have done extremely well. They do large number. This is from 2019, where they published 500 liver transplants, and 25% of their patients, or 20% in this instance, sometimes almost in some years, 1/3 of the transplants done there are done as disease donor liver transplant. So that's the only country in the East, and we'll look at Turkey a little later. Turkey also it's been possible for them to do reasonable number of disease donor transplant compared to living donor. And there have been many milestones in the Korean program, doing dual transplants and 6,000 liver transplant in one center, the first in the world. 500 liver transplant in one center. They say the first in the world. If you see there, we disagree. I think in the early days, Pittsburgh used to do more than 500 liver transplant in 1 year. It's not the first in the world, as they claim. So recently, Journal of Hepatology asked me to write an article on this subject. Why are there so many liver transplants from living donors from Asia and so few? So it's the Asians are worrying, why are there so few cadaver liver transplant in Asian countries? But the West is worrying, why are there so few living donor liver transplant in the West? I think it's probably better not to worry that they are not doing that many living donor transplants, because if the cadaver programs develops well, I think that is the best way to run living donor transplants, rather than, I think the East is pushed towards living donor because of the absence of cadaver donation. One of the reasons is probably I'm not talking about Japan and Korea, where the systems are well organized. And when you look at South Asia, and I'm not going to talk about South America, you know the system there. We can probably talk about the systems in Brazil and Argentina in the discussions. You can tell us how the system works there. But at least in India and the Indian subcontinent, the organization is the problem. The system, the governmental systems, and the NGOs to really start organ donation and put a system that people will all come together and agree to share has been a major problem in our part of the world. And I don't think it's still developed well enough in our part of the world. Whereas LDLT, Nigel also spoke about access to liver transplantation by the population. And that again is a huge problem, because 90% of the liver transplants in India are done in the private sector, and they are paid for by the insurances and individuals. So the people who cannot afford insurances, or people who cannot afford at all, who have to go to the government system, are not having access to liver transplant. But the private system has actually enabled the development of living donor liver transplant very easily, because for a living donor, really you require very experienced surgeons who are very innovative and very capable, and they can build a good team from who have been trained from the Western world. And if they're technically outstanding, it's very possible to do living donor. They're not dependent on organs, because they can create their own organs from living donor and do the transplant successfully. And that's what happened in India in the early phases. The surgeon who went there waited for organs for years together. I mean, a center will get 1 or 2 organs per year, and that is not enough to sustain any good liver transplant surgeon in India. It's only after the advent of living donor really liver transplant picked up very rapidly. And at the moment, almost 3,000 liver transplants are done here. And you can see just a comparison with the UK, which has just plateaued between 700 to 800 liver transplant. The Indian curve will start rising, and it will keep rising. And I think we'll just look at the requirement for India in a few minutes. So when you look at the global data on transplantation per million population, I'm glad to see that a lot of the South American countries are doing extremely well. I mean, Brazil is not quoted here. I think the number, one of them is Brazil. The one below Argentina is actually Brazil, doing about 10 per million population, which is extremely good compared to our standards in South Asia. And most of them are really European countries and North America, United States doing extremely well, and Spain doing even better than the United States. And you don't even see South Asia there. You don't see India there, because in terms of transplantation per million population, we are still doing less than 2%, less than 2 per million population. But when you look at the number of transplants done, total number of transplants done annually, you will see that India is second to the United States, already performing around, this is China, sorry, third after China. So it's United States, it's China, and then it is India. Most of the Indian numbers are really living donor liver transplantation in blue, performing over 3,000 liver transplants. So that shows you, even though the numbers are so large, it's not really, it's performing less than 2 per million, because the population of India is somewhere around 1.3 to 1.4 billion. And this tells a story, really. I mean, we are doing 3,000, but there is a potential to do almost 5 times more, 15,000 liver transplants a year. And if we perform that, probably most of half of really the transplants around the world could be done in China and India together. So there is a huge potential for expansion of liver transplant in these countries. And I think that the Eastern countries have done extremely well, even though there has been no access to large numbers in the beginning with cadaver liver transplant. I think in terms of numbers with living donor, they've gone up. The understanding for really the small foci syndrome and how one approaches small foci syndrome have been very varied. And if you look at the Asan Medical Center, they will do portal modulation, but when the GRWR is less than 0.8, they resort to dual grafts, which many may not agree. I mean, we did 3 dual grafts successfully, but I don't believe the principles of dual grafts, having 2 donors for 1 recipient. And if we understand the dynamics of the portal flow and really modulate the portal flow through splenic artery ligation, splenectomy, or hemiportocable shunts, I think we should be able to do. Now we comfortably do GRWRs of less than 8 and even 0.6, 0.65 and over 0.65 is also now become acceptable. And also, I think we have been able to replicate everything that we did in the UK in terms of auxiliary liver transplant. Now we have a large series of auxiliary liver transplant for acute liver failure in children, and also metabolic liver disease is a huge problem in our part of the world, and the auxiliaries done for metabolic liver disease is also large in our program. And we had invited reviews for a poll for metabolic liver disease in particular, because I'm not going to go into details of the pros and cons of auxiliary liver transplant for metabolic liver disease, but it's not been so popular because there has been problems with long-term graft atrophy and losing these grafts. And one of the innovations that we were able to perform was actually swap the livers between 2 metabolic patients, one with propionic acidemia and one with Crigler-Najjar syndrome, and then swap the livers. So one liver cancel the metabolic abnormality of the other liver. And this transplant, if you had the right sort of patients waiting, you can actually do transplants in these children without, these are non-cirrhotic patients, so you can do without any cadaver or a living donor organs. And I think one of the problems when you got such a shortage of cadaver organs is it's not uncommon to have no compatible donors within the family. The family members, I mean, one can be A and the other can be B. And there was a legal possibility to really swap livers between families which are unrelated. Technically, they are unrelated liver transplants, but they are related liver transplants. And we did our first almost 8 years ago, and now we have done 6 swap liver transplants. But now I think with this is also becoming less common because of really ABO incompatible liver transplants, which we have taken on in a big way. We have done 28 ABO incompatible liver transplant, and a huge advance, huge understanding of this has changed enormously. And you can see there is an era difference in the Japanese who started ABOI liver transplant. And now I think most people can do comfortably ABOI transplants with almost equivalent results without any antibody-mediated rejection or intrahepatic biliary strictures. You can see that the more recent series have got 0% incidence of antibody-mediated rejection and intrahepatic biliary strictures, and that's been our experience as well. From 2010 to 2020, I think I've not counted the last 1 year. In the last 1 year, even with COVID, we have done 140 transplants. So we have done over 2,000 liver transplants, and I think the outcome has been pretty good compared to anywhere else in the world, really. And the pediatric side, we have done 456 transplants in March 2020, and I think after that we have done another 40. So we should be reaching 500 liver transplant in our Chennai center now. Now, one of the other things that drives really people in the Eastern countries is the competition that develops, because a lot of these are unfortunately private centers, and we need to keep ahead. And now I think in terms of donors and the scars and the improving the operations for donors, minimally invasive is becoming very popular. Particularly, really the surgeons from France have been very much into laparoscopic hepatectomies, and now they are performing most of the pediatric, at least laparoscopically, and then a large number of Koreans have now started doing these donor hepatectomies laparoscopically, and the robotic as well. And there have been, it's quite fashionable now to actually have consensus meetings and come with recommendations. And I've been involved with one of these, and now it's well recognized that it becomes, at least for the left lateral segment, it's a standard of care, and for the right lobe, there needs to be more evidence for it to become a standard of care. We have gone into really the robotic techniques for donor hepatectomy. And this publication from Dieter Broding, who's probably now has the largest experience with robotic donor hepatectomy, and their publication really states that one should have a mastery of laparoscopic approach before venturing into robotic hepatectomy. And I'm somebody who left general surgery before laparoscopic surgery became popular, with the very really basic skills, probably no more than cholecystectomy. And it was a big worry for me to really get robot, the Da Vinci Xi system. But I found that it is really very easy to adapt the system. If you're a good open surgeon, you're able to perform these operations. And we got this in the middle of last year, in the middle of COVID, really, and it took some time for us to get started. But in the last 6 months, we have started with left lateral segment, and now we are doing right lobe, and we are able to very comfortably do, I think the first 5 cases, we did a planned conversion to a midline incision after about 3 hours of working on the robot. But after the 5th case onwards, now we have done 32. These are the numbers for the 27. This is part of a publication which has been sent, really with no blood transfusion. And even the operating time for the robotic hepatectomy is similar to the open operation. And in terms of the recipient outcome, there has been no mortality on the recipients done through, and there has been no damage to the grafts. And I think I want to finish my talk with that. If you're interested, if Leila would permit, I would like to show a video of a donor left lateral segment donor hepatectomy, robotically done. I'll skip a little bit and go inside. This is, I'm the consult surgeon here. And I'm somebody who never did laparoscopic resection, and you can see how comfortable it is for the hand movements to do this. He probably show you just the porta hepatis dissection and a little bit of the transection. Just 2 minutes. The falciform ligament and the left triangular ligament there. The axis is extremely comfortable to do. The range of movement that you can achieve with this equipment is much more than your own hand. It's a porta hepatis dissection. Can you guys see the video? It's all very quiet. I'll just keep skipping so we can move a little bit faster. The vision is actually far superior to even an open operation here. Let's skip a bit more. So the transection is done with Cusa and then stapled and removed. I think I'm going to stop here. Hello. Yeah, I think Leila, I think that's good. I think I've stopped there. Just a demonstration of what can be achieved even in our part of the world. Thank you.
Thanks a lot, Professor Rela. It was a really nice lecture and video. We will go to the clinical case and then debate everyone together. I'll ask Fabio to present the next presenter.
Dr. Rela, astonished video. Thank you to show us. And now we're going to call Dr. Wellington Draus. He's coordinator of the USP Universidade de São Paulo liver transplant program. And he will show us a case from them. And then after we have a discuss about this case. Wellington.
Thank you so much. Thank you, the organizers, for the kind invitation. It's an honor for me to participate in this great session with great hepatologists and also great surgeons. It's interesting that Dr. Rela already told us about ex situ resection or autotransplantation. This is not a new procedure, of course, but maybe we have new indications or we can treat complex cases and maybe avoid to transplant them with this kind of technique. So the first one is it's a 72-year-old lady with a big retrohepatic tumor in the abdomen, the vena cava tumor, 14 centimeters. And she underwent laparotomy in March 2020 in another center in Brazil. and was considered irresectable. They biopsied them there, and it showed the doubt about a leiomyoma and leiomyosarcoma. She had also diabetes and IPMN. This is the image. So you can see here Cabo tumor going down.
Very similar to the case I showed.
Yeah, it's similar than yours. Yeah, that's true. And it's compromising the right renal vein also. And so it's a big tumor. And here I'm going to show a quick video. It's a 3 minutes video. So the hilum, the hepatic hilum. This is where they biopsy the tumor. So we have like a growing, anterior growing tumor, the tumor behind the liver. And we mobilize all the liver with the caval vein. And in this case, we did it with the veno-venous bypass. So we inserted the femoral vein cannulation, and we dissect also the axillary vein to return the venous blood. So it is machine. It's a simple machine. It's it's simpler than they do in extracorporeal for heart operations, for example. So here we are removing all the specimen, the liver, and together with the tumor. Okay, and we perform the resection in the bench. So we are cutting. In this case, the patient had already some collaterals in the left renal vein. So, and the caval vein was totally thrombosed. So we didn't perform the caval reconstruction. We removed the tumor, and we reconstructed the vein, the hepatic veins with cadaveric vessels. And here we perform a renal anastomosis. So we were able to keep the right kidney doing this renal anastomosis because of the left venous vein had already a good collateral for the drainage. So this is the reconstruction here. So we used cadaveric iliac vessels to perform the reconstruction. And this is we are removing the tumor. So this is the right, left and middle, and here the iliac vessels and the hilum. And we did the reimplantation. So this patient, although she's 72 years old, the patient did very well. She recovered well after the surgery. It's a big surgery. She had only lymphatic fistula. I'm going to show you. This was a problem for us, but the radiologists here, they succeed to embolize the. So this is the image. So they succeed to embolize the lymphatic system, and so she did well after this. And the cold ischemia time was 275 minutes, warm ischemia time 40. She was extubated in the first POD. The peak of transaminase was around 2000. ICU discharge, the fifth POD. So this was the complication, but the treatment was successful. Second case I'm going to present one with bypass and another one without bypass. Sometimes you could do this without bypass. And the indication sometimes is when you have a compromising the hepatic veins, for example. So this is a 60-year-old lady with a huge hepatic hemangioma involving all the right liver and the segment 4. The patient was very symptomatic because of this big mass compressing the cava vein, the duodenum, the right kidney. She had also some symptoms of low blood flow because of this. And the tumor was considered irresectable at the beginning because it was so tight to the left hepatic vein and also the left pedicle. And it was considered so dangerous because it was like vessels in this big hemangioma tied to the only pedicle and left vein. That the patient was listed for liver transplant. And she received extra points, 29 points in MELD score. She was just to be transplanted when we discussed her case in our multidisciplinary meeting. Professor Carneiro is here, and he was in favor to try to resect this hemangioma instead of transplant her. So this is look at the hemangioma. It was so tied to the left pedicle and left hepatic vein in the remnant. It was quite big, the segment 2 and 3. So you can, the right kidney is here, and the aorta and cava vein was like displaced to the left side. And so this was the external aspect. The abdomen, it's like with a mass, huge hemangioma. So the first step was to tie the right hepatic artery. This was the hepatic veins repaired. And so this, we did, the first was the procedure pigback from the left side to the right, and after in the right side, and the chylon. The liver was not not good shape, you know, because I think the vein was chronically compressed by the tumor. So we had like a blue liver. I mean, it was like dark. The perfusion, the ex situ perfusion, and after all the blood was removed, this liver was like almost 5 kilos. So the hemangioma with the blood, maybe it was like 8 or more. And we performed a caval vein, temporary caval vein anastomosis with a shunt, with a iliac vessel. And here the resection, we were careful because of the vein, the vein we have to keep, and the pedicle. And we removed the tumor, and this was the remnant. So look at the liver, the aspect was not so good. And we were like a little bit afraid. We did a venoplasty. We were able to keep the middle hepatic vein also. And after this, the implantation, so in the end, the reperfusion of the liver. The liver is quite heterogeneous, was not so beautiful. It was the bridge, bleed a lot, and the final aspect of the liver. So it was, but still the patient, we had a big cold ischemia time, a warm ischemia time of 25 minutes. Although all this complex procedure and the big ischemia time, she was extubated in the first POD, and the peak of transaminase was not so high, 600 and 400. And the ICU discharge in the fourth POD. She recovered well, and no postoperative complication. This is our series. We have 6 patients so far. half of them use bypass, and all of them with huge tumors. Maybe it's quite difficult or impossible to do it in situ. And in this case, it's interesting because the last case we avoid to transplant a patient and for a benign disease. And so we had 2 deaths, one 18 months after the surgery because of COVID, and another one 4 months after the surgery because of infections, complications, this biliary complication. And all the other patients are alive. So some questions to discuss is ex situ resection. Is it a good option to avoid liver transplant, especially in benign tumors, as we showed here, that was considered irresectable, and another ex situ resection could replace or instead of liver transplant in case of cancer, compromising the caval vein or hepatic vein, especially in cases of bad biological behavior, where when you do the transplant in these cases, maybe you have a higher chance of recurrence. And in this also is something we can discuss about, is the probability of an ex situ resection in transplant centers slower than a big ischemic time complex liver resection when you keep the liver in a big warm ischemia time. So this concept is maybe more is less in these cases. Thank you so much again for this kind of invitation.
Thank you for your presentation. And now I'll introduce Professor Bernardo Sabá. He's a professor of the University of Pernambuco here in Recife. He worked with us in the transplant program. Professor Carneiro, Luis Carneiro, he is a professor of the liver transplantation here there in Universidade de São Paulo. And the other panel Palestrants can talk about. I think the questions of Wellington is very good. I'd like to see the opinion of Dr. Rela, Dr. Nigel, and others.
Thank you, Professor Andrews, for the nice case and for the opportunity to see your service and be here with you in São Paulo, and Professor Carneiro. I would like to ask if you could leave the slide on with the questions. Can you share the screen with the questions? And I think if Professor Rela and Professor Heaton and the other professors would like to comment about cases, similar cases, and what they think about these indagations and questions from Professor Andrews and the University of São Paulo.
Can I say something? Well done. I think they are very interesting cases. It's the first case, the caval tumor, is very similar to my case actually. You went on a systemic bypass, but you didn't replace the caval. What was the need for you could have gone on a portal bypass alone, but there was no need to really put a cannula into the groin and do a systemic bypass there, because it's been an occluded IVC for a long time, well collateralized, and also you didn't have to reconstruct it again. So that was just a wasted step, trying to put a cannula into the groin.
Yeah, you are right. But sometimes in these cases, you don't have only like a retroperitoneal shunt. Sometimes you have the wall shunt, and you just cut it when you open the patient. So in these cases, sometimes as you are going to use the bypass anyway, if you put another amount of blood in this system, maybe you keep the patient more stable hemodynamically. So I think it's not you don't have a big disadvantage to put on the femoral blood also in the shunt, but it's possible.
Because I didn't do a bypass in that case, yeah. And the renals also were not reconstructed. The flow was good. The renal function was good pre-op, and I didn't even reconstruct the renals.
Neither there.
Yeah, both renals have been occluded for such a long time. They had collateralized, and the patient had a good urinary output throughout.
Yeah, this case in particularly, we had to cut the right renal vein too close to the kidney, so we cut the collateral. So in this case, particularly, we have to reconstruct. We did it once. I was in French in a renal reconstruction, and another case again here many years ago. And this was the third case we did the renal reconstruction because of the left renal vein is longer. In many times this vein have more collaterals than the right. So you can do a renal shunt, and it's I think it's a good option.
Well, that's very interesting. Thank you.
Thank you.
Professor Heaton, I think Professor Carneiro has an urgency, Wellington, he said, so if you would like to debate also together, Professor Wellington, Professor Heaton, any comments?
No problem.
No, just to say they're interesting cases and well done. They come along relatively infrequently, so it's quite difficult to build up a team to manage through. I would say probably most of the patients we see are advanced renal cell carcinomas with occlusion of the cava and growth up to the level of the hepatic veins or into the right atrium. That's probably the most common case. And then primary tumors of the cava would probably be the second. So they come through relatively infrequently. But I guess it depends on the speed of occlusion of the cava. If they are long-standing, as Mohamed said, they've got well-developed collaterals, you probably don't need to bypass that. The only point I'd make is that if you do bypass the portal vein alone with vena-venous bypass, there's a thing called cavitation that occurs, and you may get bubbles forming in the head of the biomedicus pump, and you can get air embolus being generated. So if it goes on for a long period of time, you need to have a bubble monitor on the circuit. But otherwise, no, I think they were very nice demonstrations. Thanks.
Thank you.
I think you're right, Nigel. I think that's the most important reason why you may want to have a systemic bypass as well. But then again, I think the modern pumps can do as low as 500 mils per minute as well. So if they don't suck too hard, it's okay.
Yeah, and it's also important to do it like as short as possible circuit with less tubes. So if you do it, you put the pump close by and short circuit. I think it's better for this.
Thank you. Professor Seda, Professor Tekin, anyone have any more debate or comments? Also from Professor Rela's presentation. I think I have a small question for Professor Rela about Professor Rela about the CUSA. I think everyone asks about robotic and the CUSA. How does he manage? What does he think about the robotic CUSA?
The robot doesn't have many transaction things. We use the harmonic in the robotic, but we find sometimes it's much quicker for the surgeon, the bedside surgeon, to use a CUSA. For that, the only problem is you just have to, the CUSA length may be a little short to go through, so you have to put it, the ports of the robot are all at the level of the umbilicus or just a half a centimeter above the umbilicus, but this you have to put in between, so it comes in front. Generally, in principle, they say the ports, the assistant ports, the bedside port shouldn't come above the robotic port. But we find that for transecting with, so technically it is like a hybrid procedure. The bedside surgeon does the accuser, not the robot. So it's a laparoscopic accuser that we use for transection. But quite often we also use the harmonic to complete, but in this case it was accuser, and we find that much faster with accuser to do that.
I think Professor Seda has raised his hand, also has large experience in living donor transplant.
Yeah, well, I think, I've not been part of any panel of discussion on a laparoscopic donation for pediatric patients. And I think that when we say, Dr. Rela, when we say that it's a standard of care, I have read this in a bunch of papers, that it's a standard of care, the laparoscopic left lateral segment donation for kids. We've done 6 cases here, but the costs are prohibitive because we compared, the time in which the donor stays in the hospital. It's about the same, but the price of the instruments is much higher. So I don't agree with the with our friends now when we're saying that there's standard of care in countries where you have the resources to spend on that on such care. So what do you think about that?
Yeah, I fully agree with your statement. I think if you look at the first consensus meeting, it calls it a standard of care. But I was a jury in the second big consensus meeting where I specifically wanted that removed as standard of care. So you will find that the second paper in the annals would not call it the standard of care. You cannot actually call it the standard of care. I mean, you can say it is equivalent to, and that's what it is true, because there is always a worry whether you're subjecting the a donor to additional risk in a laparoscopic surgery because of lack of access in when it comes to a major bleed or some sort of a disaster happening. And therefore, would that be considered as an equivalent? And at least for the left lateral segment, people consider that as an equivalent. But I don't know why you say that the cost of laparoscopic surgeries. Are you talking about robotic? I can understand the robotic procedure is a lot more expensive because currently the usage of equipment for a case would add an additional cost of something like $4,000, $5,000 just to use 4 or 5 instruments for robotic procedure. But I don't know why laparoscopic should be so much more expensive because they are all reusable equipments.
For us, the cost was between 15 and 20,000 reais more expensive. So for us, it's kind of too much money, which is around $4,000. Is it?
You're talking about the robotic resection or laparoscopic, but laparoscopic should not cost $5,000 more.
Yeah, maybe in our country you have taxes in these instruments and more taxes in these instruments, so they come more expensive for us. This is one of the reasons, maybe, I think. And
but most of the hospitals will have a full set of laparoscopic equipment anyway.
Yeah. It's disposable.
You're not buying it for a donor operation.
Oh, sure.
Yeah.
When it was, what he's saying is the disposable are more expensive.
Yeah, and congratulations. I think this in your procedure, the robotic procedure, you are combining the advantages of the CUSA and the robotic, that is to dissect the hilum, and after I don't know, but to treat, for example, the biliary tree and everything. So I think this is very good, and I think we have to follow your steps because this combining this robotic with the CUSA for the parenchyma transection, I think is very, very, very good.
I think it makes a huge difference for the donor. I mean, especially women, when they're donating, they have a cesarean scar. That's the only scar they're going to have. You know, they already have a cesarean scar and you use that. And the rest of it is all small dots, really. And I think it also, I mean, nowadays, we have started doing even transplants through a midline incision. All of our donor, even right lobe donations are done through a midline incision. We don't use the L or the Mercedes incision anymore.
Thank you, Professor Rela, Professor Andreas, Professor Seda. I think due to the time, thank you, Fabio, for moderating together. I think we have a last comment from Professor Tekin, and then I'll pass to Professor Leila to finalize the event. Professor Tekin, thank you also.
Yeah, thank you. It was wonderful talk, Dr. Rela, and incredible 2 cases. Not to add too much, but I was trained with bypass transplant a lot. We used to do groin and axillary approach, and it's not easy. It's time consuming and some complications with the axillary. As long as you don't need high flow nowadays, if you need it, you can maybe just put a cannula to the groin and also the neckline with a 12 French. You can get away with low flow and do the bypass like that. You can save some time and avoid complications unless you need a very high flow from Keva.
Thank you.
That's true. But I think here we have this pump. I think it's and when you have this, I think it's easier because to know how it's gonna work, I think it's better to prepare everything. Sometimes we are afraid the patient is not we want to keep many hours in doing the bench operation. So sometimes I think this gonna be more stable. But you're right. We have this option.
I think Professor Sabah has some comments, or can we, I think, end?
Obrigado, Luciano. Nada a acrescentar, somente elogiar aí os participantes e a organização do evento, essas importantes contribuições. Boa tarde para todos.
Thank you, Professor Sabah, Prof. Fabio. I think everyone in behalf of Professor Leila, I think we need to end, and thanks for exchanging this experience. And hopefully next time we can be back together in Brazil, in the beach sometime, and around the world. I think. Thank you very much for everyone, and Fabio and everyone.
Thank you. Bye-bye.
Até mais, hein? Tchau.